Hello, everyone. Thanks for tuning in to this session. My name is Jason Fogg, and my co-chair colleague is Professor Tan from Singapore. So, welcome to Symposium 8. We'll talk about current advances in atopic dermatitis, urticaria, and hereditary angioedema. So in this session, we have 4 speakers with us. Let's welcome the first speaker, Professor Mauer. He's going to talk about updated guidelines on chronic urticaria. So,
hi, Jason. Hi, all. It is nice to be with you. Can you hear me? And can you see my slides? Super. Okay. Well, I'd like to thank the organizers and congratulate them for putting together such a fantastic conference, and of course for allowing me to be in it with chronic urticaria, which I think really has so many new things to offer that I will jump right in and bring you on board with the new update and revision of the guideline. This is now also a APAACI guideline, so a lot more input from Asia in this update and revision of the international guideline, and also more application to Asia than previously. More expert, more recommendations, and I will focus on what came out of the consensus conference hybrid here in Berlin end of last year, and of course the consensus process that led to the recommendations of the guideline. And I will focus, although there are more than just the ones that I will cover, focus on the recommendations that deal with diagnosis and the ones that deal with treatment of chronic spontaneous urticaria. Please also check out the other recommendations on chronic inducible urticaria. And just to bring everyone on board, we still, with the new guideline, classify urticaria as acute and chronic based on the duration, and as spontaneous and inducible based on the relevance of a definite trigger, such as cold urticaria. Most patients have chronic spontaneous urticaria, and I will focus on that. Comes in 3 phenotypes. Now, most patients have both wheals and angioedema. Some have exclusively wheals, some have exclusively angioedema. All of them are considered chronic spontaneous urticaria. And the guideline addresses the question, well, what should we do when a patient with chronic spontaneous urticaria walks into our office? Now, we know what patients want to do. Now they come to us and they say, doctor, you must do that one test. You must find what I am allergic to so that I can stop eating it or stop breathing it or stop putting it on my skin. And we know that this is not a good way forward. We need to do diagnostics, but not allergy diagnostics, because that is not the underlying cause. In fact, we should talk to our patients about what we know, and we should explore our patients for the 7 C's, we call it. No? You see 7 words here, starting with C, and I will go through them one by one to give you an idea of what's behind the 7 C's of chronic spontaneous urticaria diagnosis. We should confirm that chronic spontaneous urticaria is chronic spontaneous urticaria. And we do this by a setup of diagnostic history taking and a basic set of tests that we want to see in all patients with chronic spontaneous urticaria. ESR and or CRP are old. That's in the previous version. Differential also in the previous version. What's new? IgE and IgG anti-TPO, and I will share with you in a bit why that can help to confirm the diagnosis and go deeper to talk about where it comes from. The general setup is very clear. Let's not do massive testing in our patients unless there is something in history that guides us to a question that should be addressed with a test. So let's go there. Confirm. What else can it be? In my experience, the problem is not that we miss other diagnoses when we diagnose urticaria. The problem is, especially in GP and family practice, that urticaria patients are diagnosed with diseases they don't really have. But once we have a patient with wheals, angioedema, it does make sense to think about other diseases that could explain why they have these signs and symptoms that are not chronic urticaria. And for those with wheals, that could be urticaria vasculitis or an autoinflammatory syndrome. And those with angioedema only, that could be bradykinin-mediated angioedema, such as ACE inhibitor or hereditary angioedema. But that's the smallest and easiest part for us as specialists. Let's look at the cause. Today, we think that there are two known causes and other, as of yet, unknown causes. And the two known causes of chronic spontaneous urticaria both involve mast cells, activated mast cells by autoimmune mechanisms. On the right, you see autoimmunity type 1, where IgE autoantibodies to autoantigens drive mast cell degranulation. That's the more common one. More than 50% of CSU patients have that. On the left, you see autoimmune chronic spontaneous urticaria, where autoantibodies of the IgG class go to mast cells, bind to them, target them, activate them, make them degranulated. Up to 30% of patients with chronic spontaneous urticaria have these autoantibodies, and the best standalone test that you can do to diagnose that is a basophil test. But there are tests that give us a clue in routine clinical practice on whether it's autoallergy or autoimmunity. And IgE anti-TPO come into play here. Why? IgE tends to be normal or high in the autoallergic one, but it's usually low in the autoimmune ones, less than 40, and often combined with IgG anti-TPO, that Hashimoto thyroid autoantibody. And so that's why IgE and TPO are now, IgG anti-TPO are now a recommendation for specialists who see patients with chronic spontaneous urticaria. We are to look at comorbidities. This is often overlooked, and it makes a huge difference. Patients with chronic inducible urticaria on top of their chronic spontaneous urticaria respond differently to treatment and should be counseled differently. Patients with other autoimmune diseases should be treated for these autoimmune diseases. And of course, 30% of patients, because of their chronic spontaneous urticaria, have manifest depression, panic disorders, anxiety, and should be treated for them. Consequences, cofactors, well, let's look at this. I want to jump to components because this is very interesting. We think that the underlying autoallergy and autoimmunity are the causes that lead to mast cell degranulation. But what patients tell us is very different. They observe that stress, certain foods, drugs, and also infections can make their disease worse. And that's true because all of these conditions translate to triggers, modulators, that act on mast cells. So it is important to bring all of this on board to have a comprehensive view of urticaria. And finally, the course. We must look at the course and must use tools that do that. My favorite one, the UCT, it is in the guideline for a long time now. And for the first time, we also have the angioedema control test as a recommended tool. Works very similar to the UCT, 4 questions, 5 answers, you get points. And just like the UCT, 0 to 16, where 16 is complete control, this is what you want to have, and 0 is no control. Now with the AECT, 10 is a good first goal, well-controlled disease. You remember that with the UCT, that is 12. So both tests very suitable. Both tests, you want your patients to score 16 points and be on the good side. Be a pro. Use the PROMs in chronic spontaneous urticaria as well as in chronic inducible urticaria, where we now also have CINDU PROMs, patient-reported outcome measures. And that brings me from the diagnosis to optimized treatment, because when we do this, then we have a much better picture of our patient, including how our patient will respond to treatment. And the treatment really has still the one goal that the guideline has always proposed: treat the disease until it is gone, until the disease goes into spontaneous remission, and so well that patients have no more symptoms. Give them complete control, give them normal lives. This is the target of our treatment: complete overlap of no more wheals, no more itch, no more angioedema, complete control, being able to do everything that you want to do without the risk of developing wheals or angioedema. So how do we do that? The new revised and updated version of this guideline has a 3-step algorithm, and you will recognize some of these steps from the previous versions. 2nd generation antihistamine, standard dose, don't wait too long if it doesn't work, and go up to 4 times the standard dose. If this doesn't work and you have access to omalizumab, that should be the next step. Add omalizumab at the standard dose, 300 milligrams every 4 weeks, subcutaneous. And if that doesn't work, go up in the dose and or shorten the interval. You start to recognize a pattern here, and that is to step up, to optimize, and to step down if you must. Now, what does the guideline say we should do in terms of optimizing the treatment for our patient? When we have a UCT of less than 12, we need to act. We need to step up the treatment and provide better treatment to bring patients to at least well-controlled disease. UCT of 12 to 15. Then we can start to optimize. But really what we get to is, let's bring our patients to 16. That is the treatment goal. Let's work towards that treatment goal: complete control, complete response. And once we have achieved that, and only then can we think about stepping down the treatment, think about doing the same with less, and maintaining patients at that level for a long time. I want to give you just one example how we implement that. We know that autoimmune chronic spontaneous urticaria and autoallergic chronic spontaneous urticaria are different. They're treated the same way, but we have to expect in patients with autoimmune chronic spontaneous urticaria that antihistamines show a slow and poor response. Omalizumab have a lower response rate and it starts slow, whereas the autoallergic ones, well, they have a high response rate. And that gives us guidance to manage expectations in our patients and to be ready in the autoimmune chronic spontaneous urticaria patients to step it up. And it is today so easy to identify these autoimmune chronic spontaneous urticaria patients. How? They have low IgE, elevated IgG anti-TPO. That is the best routine clinical marker for you to identify your problem patients. And with that, I want to wrap it up. The guideline brings a lot of new things, including new unmet needs. And what the guideline says should be investigated are targeted treatment, better treatment, individualized treatment. And for that, of course, we need new treatments. And I'm very happy to report to you that many novel treatment options are now being developed. In fact, everything that's a blue word on this slide is a target of novel treatment in being investigated with antibodies or small molecules in clinical trials today or in clinical development programs. In fact, when we go back to the overall understanding of how this disease works, where mast cells are the key culprit with all the mediators that they release that act on the skin, including the nerves to produce the itch and the blood vessels to produce the wheal and flare and angioedema reactions. Well, there are now many programs, all of them here in green, that look at novel anti-IgEs, complement targeting, dupilumab and ralitsumab and mepolizumab, but also anti-TSLP, anti-KIT antibodies, many things that are today under development. So stay tuned, but just quick summary here. Better diagnostic approach is facilitated with the 7 C's of the new guideline. We must monitor our patients, and that is best done with UCT and or the ACT, we should treat urticaria until it is gone. And that is best done by stepping up the treatment as quickly as possible to bring patients to control, optimize that control, and only start to step down when we suspect that the disease may have gone into spontaneous remission. And let's work together as a global urticariology community to address the unmet needs, and that includes running these clinical trials to help to develop better new treatment options for patients fast. I want to thank all the UCARES who are on board here. If you're interested in what we do as the global network of Urticaria Centers of Reference and Excellence, go check it out at www.galen, with a 2 between the A and the L, -ucare.com. And do join us in Hiroshima for the biggest standalone meeting on urticaria this year, the UCARE conference, December 9 to 11. Check out the conference website. Join us if you can, in person or remotely. We're looking forward to having you here. With my greetings from the UCARE and CARE here at Charité. My email address is on the bottom. Please send me your questions that we don't have time to answer now. Thank you very much for having me.
Thank you so much, Professor Marvel, for the fantastic talk again.
Thank you very much, Prof. Mara. It gives me great pleasure to introduce our next speaker, who is Prof. Ken Wu, consultant in the Department of Internal Medicine, Allergy and Immunology of Gleneagles Hospital, Malaysia. And Prof. Wu will be presenting today on current updates on atopic dermatitis. Prof. Wu, please.
Thank you very much for the kind introduction, and thank you, the organizers, for inviting me. I send greetings from Masai. Without further ado, I'm going to achieve 3 objectives through my talk today. The first one is to introduce the new concept of atopic dermatitis as a systemic disease. And then I'm going to highlight JAK inhibitor use in atopic dermatitis. And finally, demonstrate how environmental pollution can affect atopic dermatitis. So we all know, and we've been taught, that psoriasis is a systemic disease. I'm going to try and convince you or introduce the concept that atopic dermatitis itself is also a systemic disease. There's been higher immune activation that has been reported in peripheral blood from patients with atopic dermatitis versus psoriasis. And there's increased activated T cells, increased circulatory cytokines, and also increased cardiovascular associated markers. This is a nice study that was published in Allergy in 2015, looking at 3 population-based studies. And the first study was the famous NHANES study. And they looked at the data of flexural eczema in the past year. And it was correlated with higher odds of coronary disease, heart attack, and congestive heart failure. The 2 studies was NHIS 2010 and NHIS 2012. And there is a 1-year history of eczema, which nicely correlates with coronary artery disease, angina, heart attack, other heart diseases, stroke, and peripheral vascular disease. This is another nice paper that was published in BMC Medical Genomics that looked at a meta-analysis of derived atopic dermatitis transcriptome. And this is a busy slide, but essentially they found 2 things from this study that they'd done. Was that this atopic dermatitis transcriptome was associated with novel pathways, such as the atherosclerosis signaling pathway, indicating an increased risk of cardiovascular disease. And the 2 molecules that they identify is IL-37 and selectin E. The other thing that they interestingly discovered, that there was wide lipid abnormalities, and for the first time in vivo, they correlated the Th2 immune activation, which we see in our subjects with atopic dermatitis, with downregulation of key epidermal lipids. And they suspect that the cytokine role based on this study in terms of the lipid disruption leading to barrier disruption that we see in atopic dermatitis. And finally, I want to highlight this interesting study that was published in JACI in 2020, where they did FDG PET MRI in subjects with moderate to severe atopic dermatitis and matched it with healthy individuals. And you can see here, here's the MRI portion. Over here on the right is the PET MRI. And on top here, they looked at the aorta. Compared to healthy normal controls, you can see increased inflammation in the aorta in these subjects with atopic dermatitis. They also looked at the carotid arteries, and you can see here on the right, compared to controls where there's no inflammatory uptake, the atopic dermatitis subjects showed increased uptake in the carotids. Furthermore, they also divided the severity of the atopic dermatitis with inflammation, and they found compared to the healthy controls here on the far left, the more severe atopic dermatitis phenotype was correlated with increased uptake. So, of course, this is a very small study, but it is the first of its kind that showed that there is greater vascular inflammation in moderate to severe atopic dermatitis versus healthy controls. They also showed the correlation between higher inflammation with disease severity of atopic dermatitis. And of course, more studies are needed, and especially before and after treatment, to see whether treatment of atopic dermatitis will modify the vascular inflammation. I'm now going to go to the second part of my talk, which is JAK. Do you know JAK in atopic dermatitis? We all know the JAK-STAT signaling pathway, where there's the cytokine which binds to the receptor, which phosphorylates the STAT protein, which then enters the nucleus and induces target gene expression. This is a very busy slide to show that JAK inhibitors are not new. These are the published results from phase 3 trials of JAK inhibitors for atopic dermatitis. And you can see multiple different JAK inhibitors with different efficacy. The one I want to highlight is this paper that was published in JAMA Dermatology in August of this year, where they compared upadacitinib, from now on I'll refer that as UPA, and dupilumab, which I will from now on refer as Dupi. And they compared UPA versus Dupi 1-to-1. And they wanted to see what happened. And just a brief reminder of what happens in the IL-4, IL-13 signaling pathway. Dupi binds to the IL-4 receptor alpha, thus blocking both IL-4 and IL-13 upstream. And the JAK inhibitors block the signaling downstream. And you can see there are many types of JAK inhibitors, and JAK inhibitors are not specific. They bind all these so-called cytokines, which we have found to be relevant in atopic dermatitis. Over here is UPA, which is a JAK1 specific inhibitor. In this study, they looked at it's an international study where there's 377 men and 315 women, 126 centers, 22 countries, and they randomized 1-to-1 to Dupi 344 here, UPA 348. The primary outcome is the EASI-75 score at week 16. And this is how they did it. You had a screening period. There's a double-blind, double dummy. One arm got UPA tablets with placebo injections. The other got Dupi injections with placebo tablets. And you had every 2 weeks injection. That's how you administer Dupi. And these are the comparison between the two arms, pretty similar. And you can see here, UPA perform much better than Dupi. And you can see they received the increased proportion of patients that achieved the EASI-75 score at around 4 weeks, peaking around 8 weeks in this study. Also, a significant portion achieved the EASI 90 score, more so than Dupy, and even a proportion achieved EASI 100 scores compared to Dupy. And also, in terms of the pruritus score, you can see here, the UPA arm did significantly better than the Dupy group, and they did it much faster. Of course, we're all interested in the side effects, and I want to highlight the significant side effects found in this study. Adverse reaction with significant possibility of being drug-related. Dupy is over here about 37%, UPA is 48%. However, it's pretty well tolerated. Adverse events leading to discontinuation is pretty low, 1.2% in Dupy, 3.2% in the UPA group. Now, if you split out the adverse events, this is what we see. We definitely see more infections in the UPA group, serious infections, opportunistic infections, particularly zoster in the UPA group. And also they noticed increased hepatic disorder in terms of elevated liver enzymes in the UPA group. They also found more hematological abnormalities in the UPA group, where we see anemia, neutropenia, and lymphopenia, with also elevated CPK. Now, interestingly enough, the elevated CPK did not lead to drug discontinuation in the UPA arm. And there's also more skin side effects. There's particularly of note is acne. About 18% in the UPA arm developed the acne. 7.5% developed upper respiratory tract infection. CPK I already mentioned. We see definitely nasopharyngitis, headaches, and conjunctivitis, which is more common in the Dupy group. There's also elevated incidences of folliculitis in the UPA group. So the conclusions from this study is certainly during 16 weeks of treatment, UPA demonstrated superior efficacy versus Dupy in moderate to severe atopic dermatitis with no new safety signals. I highlighted what are some of the adverse events. Some of the commentary I have is below. Definitely UPA works fast, and for us countries which have funding issues for our patients, perhaps we might want to consider pulse dosing, and it might be a subject for studies in the future. And also certain countries here in Southeast Asia has increased risk of tuberculosis. This might be a signal that we might see. And also combination therapy with biologics. We do note that the UPA is being used with methotrexate in certain rheumatoid arthritis patients. Certainly we want to know if we can use it with other biologics as well. This is the final part of my talk. This is in 2019, where we were affected in Malaysia by the Great Haze. Schools were closed. I was seeing multiple patients that streamed into my clinic for increased atopic dermatitis flare. And this was an elegant study that was published in Nature Immunology that found the receptor called aryl hydrocarbon receptor, which binds to PM2.5 on the skin, which then upregulates artemin, which induces hypersensitivity and innervation by sensory nerves, and they trigger increased sensation of itch, which then leads to scratching and disrupted skin barrier, leading to atopic dermatitis flare. This is a nice review paper published in JACI in 2013 that demonstrated and showed that inhalation of PM2.5 or even smaller can lead to systemic circulation and inflammatory triggers, leading to cardiovascular events and more. And so this is a nice study that was published also early this year in JAMA Dermatology, where they did a cross-sectional time series study of air pollution resulting from the California campfire in November 2018. And they measured fire status, PM2.5, and satellite-based smoke plume density scores. And what they wanted to measure was the weekly clinic visit counts for atopic dermatitis and also topical and systemic medications. What they found was compared to the non-fire weeks, the wildfire weeks, there were increased pediatric patient visits and also increased adult patient visits. And they found that increased concentration of PM 2.5 was associated with 7.7% increase in weekly pediatric itch clinic visits. So this study found that short-term exposure to air pollution due to wildfire was associated with increased healthcare use for patients with atopic dermatitis and itch, which nicely demonstrate the benchmark research to what we see in clinical practice. And so this is a call for further research here for the Southeast Asian area. This was the severe wildfires that affected the Southeast Asia in September 2019. We even reached hazardous level in certain parts of the areas affected, and it will be nice to conduct and duplicate a similar study here in Southeast Asia. So this is the last part of my talk. The conclusion, I hope that I've come through these three objectives, is that first, atopic dermatitis is a systemic disease, and increased cutaneous severity is associated with cardiovascular inflammation. We should not be thinking of only treating the skin alone. We've seen the efficacy of JAK inhibitors, and UPA is what I've highlighted in today's talk, and it performed greater than Dupi in a 16 weeks head-to-head study. We did go over some of the adverse effects in that study. And finally, air pollution has systemic effects, and studies are now demonstrating the mechanism it plays in atopic dermatitis. Well, thank you very much for your time, and I'll see you at the Q&A session.
Thank you very much, Prof. Wu, for your enlightening talk and the insights on relationship between pollution and atopic dermatitis.
Yeah, let's welcome the next speaker, Professor Toy Lipam from University Medical Center in Vietnam. His title today is Monitoring Therapy in Atopic Dermatitis, Clinical Considerations.
So good afternoon, and thank you, Jason, for your kind introduction. And thank you, the organizer, for inviting me to have a talk in this symposium. And continue to the atopic dermatitis topic, I will discuss with you about the role of moisturizer using in atopic dermatitis treatment. Actually, it's very familiar to the doctors and patients, but there are still some clinical consideration that need to be reviewed. I have no conflict of interest to declare. First, let me introduce the epidermal barrier structure and the moisturizer. The epidermal barriers have very important function to protect the underlying tissue, and when it is impaired, it will increase the trans-epidermal water loss, decrease the stratum corneum hydration, and facilitate the penetration of the environmental pathogen like microorganisms or the allergens. So the moisturizer is very important role in restoring the integrity of the stratum corneum. So what is the moisturizer? Actually, there is no consensus in the definition of the moisturizer, and this term is developed by the marketer to promote its function in moistening the skin. And there are three key components of the moisturizer. First is the moisturizing ingredients, including three types: occlusive, humectants, and emollients. In different combination, we'll make different formulation of the moisturizer and have different function, and I will discuss in the next slides. The second component is the emulsifier and polymers, which are used to maintain the stability, the structures, as well as the thickness of the moisturizer. And the last component is the functional ingredients, which provide a therapeutic effect of moisturizer, and they could be antioxidants or several acids like hyaluronic acid or AHA. There are three types of moisturizing ingredients: emollients, occlusive, and humectants. Emollients are usually lipids that mimic the epidermal lipid layer. They fill the intercorneal side cluster gaps and thereby restoring the integrity of the epidermis. Occlusive are usually oil-based, for example, the mineral oils or petroleum jelly. they create the hydrophobic barrier over the skin and thereby preventing the loss of water by evaporation. Humectants are the hydrophobic substances that help the epidermis absorb the water by attracting the water from the deeper layers as well as from the humid environment into the epidermis, and thereby increasing the water content of the epidermis. The moisturizer also comes with different formulation or different form. There are lotion, cream, ointment, base, and gel. Lotion is the thinnest film, and the ointment is the thickest one of the moisturizer. The base is a mixture of the ointments and the powder, and gel is the special form of the moisturizer. So the appropriate selection of moisturizer with appropriate formulation is very important to achieve the good control in atopic dermatitis symptoms. So what is the role of the moisturizer in atopic dermatitis treatment? The characteristic of the atopic dermatitis skin is the defective barrier with an increased transepidermal water loss. If we use the occlusive emollient alone, it prevents evaporation. But if we use a combination of occlusive and humectants, it not only prevents the evaporation, but also restore the water holding capacity of the epidermis. And therefore, it can bring a better moisturizing effect. The role of the moisturizer in treatment of ADs is very clear, and there is a study, a systemic review in Cochrane Library showing that the use of moisturizer in comparison to the vehicle or placebo significantly increased the number of the patient who had the AD symptom improve, and also it significantly reduced the severity of AD. Although the evidence was moderate and low, but the moisturizer using significantly reduced the number of the flare-up of the AD and also reduced the amount of topical corticosteroid use. When we combine the active treatment, for example, the topical corticosteroid and together with decreased the severity of AD and decreased the number of the flares-up compared to the active treatment alone. In addition to the moisturizing effect, the moisturizer also considered a vehicle. That means it helped to improve the drug delivery. It helped the topical medicine to penetrate deeper into the skin. Several humectants like the propylene glycol is also called the penetration enhancer because it can help the topical medicine to penetrate deeper. Because of that effect, the using of a moisturizer have a very clear corticosteroid sparing effect. That means it helped to reduce the amount of corticosteroid used by the patient to treat the AD. One of the very important questions is that whether the moisturizer could prevent the AD development. There were two studies published in JACP in 2014. And they were the first studies to investigate the role of moisturizer in prevent the development of AD in infants. The first study were performed in Tokyo, Japan, and the newborns at the high risk of AD. That means they had one parent or one sibling at least have diagnosed with AD. They were randomly assigned into intervention group with daily moisturizer application and control group. And this study found that the probability without AD in the intervention group was significantly higher than the control group. That means the risk of AD development in the intervention group was significantly lower than in the control group. The second study with the similar study design were performed in the UK and US. They also had intervention group with daily moisturizer application for 6 months and the control group. This study found that the prevalence of AD in the emollient group or intervention group was half of the prevalence of AD in the control group. Also, this finding shows that the risk of AD in the intervention group was significantly lower than in control group. However, these two studies had a relatively small number of the study population. So in 2020, two studies were published in Lancet with a much larger study population. The first study called preventative study preventing atopic dermatitis and allergy in childhood. This study was performed in Sweden, and newborns were randomly assigned to 4 study groups. The skin intervention group, in which the baby were applied the moisturizer at least 4 days a week, and the food intervention group. In this group, the baby were only introduced the complementary feeding, and the combination of skin and food intervention group and the control group. The primary outcome was the eczema prevalence at 12 months of age. And this study showed that there was no significantly difference between in the AD prevalence among 4 study groups, although the prevalence of AD in combined intervention group was seems to be lower, but no significantly different. The second study, named Barrier Enhancement for Eczema Prevention, or BIT study, were performed in the UK. The high risk of AD newborns were randomly assigned into daily emollient application group and standard skincare group. The primary outcome were eczema prevalence at the age of 24 months. The observation duration was a little bit longer. And also in this study, there was no significantly different in the AD prevalent in emollient group and control group. So the recent 2 study, which large study population, showed that the early application of moisturizer in the baby with high risk of AD did not show any effect in preventing the AD development. Actually, there is an ongoing study called a community-based assessment of skincare, allergies, and eczema, or CASCADE, and the protocol was published in Trials in 2020. In this study, they will recruit 1,200 infants, and the infants are not selected for AD risk. And they have 2 study groups, intervention group and the control group. And the primary outcomes will be the accumulated incidence of AD at 2 years of age. And secondary outcome will be the AD symptom burden, comorbid allergy conditions, including the food allergy, asthma, and IgE sensitization. I'm looking forward to the interesting result from this study in the near future. And the second question is when to apply the moisturizer. And this is a frequent question asked by the patient. And the doctor, based on the guidelines, usually recommend the patient to apply the moisturizer immediately after bathing. And the best time to apply is within 3 minutes after bathing. The same recommendation will be seen in different guidelines. For example, the guidelines of Japanese guidelines also recommend to apply the moisturizer immediately after bathing. And we see the same recommendation is a publication in Asian Pacific Journal, which recommended to apply moisturizer immediately after bathing. And also we can see it in the Journal of American Academy of Dermatology. I tried to look for the evidence supporting those recommendations, but could not find. However, I found a study with a relatively small number of study population comparing the effect of immediate and delayed moisturization regimen. And they found no significantly difference in mean hydration status between immediate and delayed moisturization regimens. And our group also performed a study investigating and comparing the moisturizing effect between the early and delayed moisturization regimen. We recruited a healthy volunteer with no skin disease and the age from 18 to 25 years old. We applied 3 regimens of moisturization: non-moisturizing, immediate moisturizing, that means the moisturizer was applied within 3 minutes after bathing, and delayed moisturizing, that means the moisturizer were applied 30 minutes after washing. We measured the transepidermal water loss and straightened corneum hydration by GB skin.
We have been given some time for a Q&A session, about 10 minutes. So I will start with a question from the audience directed to Prof. Pham. And the question is relating to the different types of moisturizers available in retail. The question is how public would know how to differentiate between humectants, emollients, and occlusives from the various off-the-shelf products from pharmacies and markets when choosing the best moisturizer to apply to the skin. Prof, please.
Okay, thank you, Mr. Tan, and thank you for that question, interesting question. And I would like to share an information about the ingredients, about how can we read the label of the moisturizer. Actually, there is no guideline for the doctor and the patient to choose the best moisturizer, but we can distinguish the moisturizer based on the ingredients that listed in the label. And there is a rule for listing the ingredients in the moisturizer. It is the International Nomenclature Cosmetic Ingredient, or INCI. And the ingredients of the moisturizer are listed in the order of the percentage inclusion in the formulation. But the exception in the US that the ingredient under 1% can be listed in any order in the label. So if we can see the two labels here, the body lotion and the high occlusive, in the body lotion, we can see aqua. The aqua is always the first ingredient listed in the label. And next we can see the glycerin, and glycerin is the humectant. So this is usually in the lotion. And when we look at the high occlusive cream, we can see the second ingredients is petrolatum, and petrolatum is the occlusive. So we can know that this moisturizer has a more occlusive effect. So by seeing the ingredients in the label, we can know the effect, the characteristic of that moisturizer, and we can select the best one for the patient based on their skin condition. And one thing I think the doctor should bear in mind that it doesn't mean that the moisturizer with the expensive price will be better than the cheap one. We usually tell to the patient that the moisturizer that helps to moisten the skin is the best moisturizer for that patient. And thank you for your question again.
Thank you. There's a question for Professor Marcus Maurer. In the countries where omalizumab is unavailable or not affordable, what is the most appropriate option after four full doses of antihistamines?
Thanks, Jason. It's a good question because there are countries where OMA is not readily available or not at all. The guideline says use cyclosporin, and that's a recommendation I can fully support because it is the only other treatment for which we have evidence that it works. Now, it's not one of the funnest drugs to work with, as many of us know. You have to watch out for the side effects. You can't give it for a long time. So after 3 to 4 months, we usually stop. And this is when usually the signs and symptoms come back and we are faced with, again, the question, what do we do now? But it is good to bring peace to the system because there are very few other options that have the same rate of response as cyclosporin. With that, it is unlikely that you have another biologic if you don't have omalizumab. But if you do happen to have access to dupilumab or also secukinumab, benralizumab, and mepolizumab, these are also safe and effective treatment options in chronic urticaria. As far as we know today, the dupilumab study just came out with results that show that it is about as effective as omalizumab. So maybe some of the countries that do not have OMA have some of the other biologics that can be treated, that can be used to treat off-label, but in a good way.
Thank you.
Thank you, Prof. Maurer. There's another question from the audience for Prof. Pham, again relating to atopic dermatitis. And the question is, in which patient groups with atopic dermatitis would you recommend long-term daily use of topical corticosteroids, or perhaps recommendations for steroid sparers? Thank you.
Okay, thank you for that question. And actually, it's not related to the moisturizer, which I have talked in my presentation. However, with the patient who have the recurrent symptom of AD, we usually use the attack dose. That means we apply the topical corticosteroid like twice a day for a short time, like 2 or 3 weeks. And when the symptom is controlled, we usually reduce the dose. And we apply the topical medicine like twice a week or 3 times a week to get the control in the atopic dermatitis symptom. So if the patient cannot control with that regimen, we have to think to another treatment, but we cannot use the corticosteroid every day if the symptom is not controlled well. And I would like to listen to the opinion from Professor Ken Wu also and other professor.
I'm happy to comment. Usually, if you have a severe atopic dermatitis flare, what we tend to do is use the topical steroids twice a day, usually medium strength. If it's very severe flare, you might have to go up to the high potency topical steroids to get it under control. Then after that, we have what we call the proactive therapy, in which you apply the topical steroid to areas of the skin that are prone to flare, and you do it routinely at least 2 to 3 times a week. And that studies have shown that it can help prevent flares. Another approach is to use the non-topical steroids, which we call the calcineurin inhibitors. That can do the same effect for atopic dermatitis control. I hope that helps answer the question.
Thank you very much, Prof. Wu and Prof. Pham. Perhaps you'd like to ask Prof. Hide, what is the your experience with the use of availability or accessibility of treatments, for example, C1 inhibitor in Japan?
My experience about the use of C1 inhibitor?
Yes, I think because one of the limiting factors I think that many of us face in clinical practice is availability.
Yes. Medications for HAs are all modern medications are all expensive, but fortunately there is a special system in Japan. So patients with HA are specified as a very disease. So once experts qualify the patients with that particular difficult to treat disease, then they can get the reimbursement. So virtually there is a certain limit for the patients, but payment for the patients. So most patients do not have to worry about the cost of the medication. Very lucky, thankfully.
Thank you, Prof. Hide. I think that it's really very fortunate that the patients do have access to the best treatments available.
Got a question for Professor Mauer. So chronic spontaneous urticaria is associated with autoimmune conditions. So in clinical setting, if the autoimmune conditions is treated adequately or with good control, is it usually related or associated with good control with the urticaria as well?
Bit hard to hear, but yes, it's an autoimmune condition with IgG antibodies to the alpha chain of the IgE receptor or IgE. So that drives the mast cell activation in the skin. Why only in the skin? Maybe Michi wants to comment. Part of it is the C5 that's activated in the C5a receptor that's predominantly expressed on skin mast cells rather than other mast cell population. So that makes it a skin manifested systemic disease. The thing is that if you look for other autoimmune conditions, you do find all of these conditions to be more prevalent in chronic spontaneous urticaria and most prevalent in those who have type 2B. We call it type 2B autoimmune chronic spontaneous urticaria. So that is a risk factor. Having one autoimmune condition is a risk factor for having a second and a third, and chronic spontaneous urticaria, autoimmune urticaria is no exception. So yes, it makes a lot of sense to screen patients with CSU for other autoimmune diseases and to treat them.
Thank you very much. Yeah, I think with time, so we have to close the session. So let's thank all the speakers for the fantastic talk tonight. Thank you so much for attending the session. Good luck, everyone.
Thank you.
Goodbye.
Thank you.
Bye.